The title of this talk is Getting with the Guidelines. And my hope with this is to start a discussion about what a good guideline is, why we choose to do guideline synopses, where you might find them, and to really show how guidelines can truly impact how we view decisions regarding the care of our patients. Before I start, just want to say I have no relevant financial or other disclosures related to the content of this presentation. And my learning objectives are as follows. I want to identify the 3 rules of evidence-based practice, describe how guidelines are developed, demonstrate how great terminology comes into assigning levels of evidence and levels of certainty regarding things put forward in guidelines. I'll review 3 practice-changing guidelines that were published in the last year and a half, and then, of course, we'll apply the findings from these guidelines to a few patient scenarios. So before diving into guidelines, I think it's important for us to think about evidence-based practice in general. When I talk to colleagues across the country, one of the criticisms of EBM or EVP is that it is robotic and that there is no nuance in the application of guidelines or the results of randomized controlled trials or findings from prospective or retrospective cohort studies to the patient scenarios we see every day. And I hope with these 3 rules of EBM that I go over here in the next few slides that I can dispel EBM being robotic as a myth. On the left-hand side of this slide, you'll see a very classic evidence pyramid that has been taught in medical schools and health professional schools across the country, where we start with background information / expert opinion, and we get all the way up to systematic reviews and meta-analyses. Right below that is critical appraisal of topics, so that could be evidence syntheses and guidelines. And if you looked at that pyramid, you would have the mistaken assumption that this relationship kind of goes from bottom to top. But truthfully, not all evidence is created equal. When thinking about patients and how we apply the data from trials to patients, one important consideration is the type of question that we're asking. For a lot of patient encounters, we might be asking the question of, is this drug X better than standard of care Y? And in those scenarios, randomized control trials are the study of choice. And if there are multiple randomized control trials, then a systematic review or meta-analysis is what we prefer, followed by prospective cohorts, retrospective cohorts. When we get to questions of harm or questions of prognosis, randomized control trials are actually not ideal, often because they are really built to determine if a treatment X or Y is more efficacious than either a matching placebo or the standard of care in a pre-specified patient population. We might instead want to use prospective cohorts or retrospective cohorts because those trials usually can occur over a longer period of time than randomized controlled trials. And again, kind of give us an ability to look at questions of harm or prognosis a lot easier than can be done in a therapy trial. So not all evidence is created equal. I think another important rule is that evidence alone is never enough. As a practicing physician, for me, evidence-based practice is what I do day in and day out in the clinic. When we have patients bring things to us that are dilemmas about treatment, about potential for harm, we take that dilemma and we ask a clinical question. And once we ask that clinical question, we acquire evidence, whether that's going to sources such as UpToDate or Dynamed Plus, or if it's not readily available in those resources, going to the medical literature to try to find what is the best evidence to answer the question. Once we get that evidence, we go through some process of appraising and after appraising, applying the evidence and acting on it in some way. And to do this cycle well, we need three important things. One, we do need the best scientific evidence. And to answer the question of what the best scientific evidence is, it matters, again, the question that we are asking based off the patient dilemma. But we can ignore also our clinical experience. Over time, as we see more and more patients, that experience can color, how well we might see the best scientific evidence apply to a patient X versus a patient Y. And probably equally important, or in some cases most important, is patient values. Our patients have different values and preferences regarding what things are acceptable to them in terms of benefits and what things are not acceptable to them in terms of risk. And in order to do evidence-based practice in a meaningful way, it is important to incorporate all three of these things so that EVP is not robotic, but a really thoughtful way in which we engage into medical care. And the final rule is that clinicians make recommendations. At the end of the day, our patients have the right to agree with or not agree with the recommendations we make. And instead, our role is simply to say that I do recommend you do something, I don't recommend you do it, and I have strong evidence to support that, or I don't have such strong evidence to support that. And I think as we are transparent with our patient about what our recommendations are and why we're making those recommendations, I think it opens up the possibility to have shared decision making and to have conversations with our patients so that they are equal participants in the healthcare process. So with those rules in mind, let's talk a little bit more about clinical practice guidelines. So on that evidence-based pyramid, clinical practice guidelines were right below systematic reviews. And one reason for that is that often most clinical practice guidelines will be based off of systematic review and meta-analysis of available data. But more on that in a second. To develop a clinical practice guideline, you usually need to select a topic of broad clinical interest. You'll see with the topics we'll discuss tonight, which include intracranial hemorrhage, venous thromboembolism, GERD. These topics, cover a large proportion of patients. And with topics that are broad like that, there are multiple patient-focused questions that can be used to query the literature to find available evidence. But once you have that topic of broad clinical interest, then you need a multidisciplinary work group to review evidence. The multidisciplinary work group is key here. Certainly, if you have a condition, let's say something like chest pain, and you only have the perspective of cardiologists at the table, you might have preference for certain interventions and things that may or may not be the same as would be done by primary care physicians or emergency medicine physicians who also see patients with chest pain, but again, are coming at it from a slightly different perspective. So multidisciplinary work groups really help to, in some ways, reduce the bias that can occur with one particular specialty or treatment group. And when you are looking at guidelines, kind of assessing or determining, whether or not multiple disciplines were involved is one great way to kind of assess, how generalizable are the findings from this guideline to clinical practice. After getting a good topic and convening that work group, generally that work group is going to identify some key clinical questions. And that can be informed by their own practice. It can also be informed by patient, dilemmas that have been brought before the board, even before the work group meets. Sometimes members of the work group have worked on research themselves and can kind of bring up unanswered questions, but those key clinical questions are important because For most of us, a guideline is actionable when we can look and it is answering questions that reflect what we see in daily practice. Once you have those key clinical questions, the literature is searched and we try to find the best available evidence, and using systematic review and meta-analysis, combine the data, and after looking at the data in aggregate, be able to hopefully provide both recommendations and rationale for patient care scenarios. This is how most clinical practice guidelines are made across different subspecialties and different agencies and groups. Now, one important thing when dealing with, recommendations is usually you want to know if the recommendation is strong or weak or conditional, and you want to know the certainty of the evidence, okay? And so I want to talk a little bit more about the different ways we think about quality of evidence and certainty of evidence. So on the left-hand side, I have one distinction that we see for in terms of quality of evidence. So this is the certainty we have in the treatment effect. So to say that there is high certainty, that usually means that we don't think that any new study or any new research is likely to change our confidence in the estimate of treatment effect. Moderate would mean that further research can have an important influence on our confidence and could change the treatment effect estimate. Low certainty suggests that the confidence in the effect estimate is limited, and the true effect might be changed by a study. And then if it's very low certainty of evidence, our estimate of treatment effect is extraordinarily uncertain. So we look at whether evidence is high, moderate, low, or very low in terms of the certainty of the treatment effect. And then recommendations are usually given as strong or weak or strong and conditional. So a strong recommendation feel that the benefits clearly outweigh the risk, that it applies to most patients in most circumstances. And generally, strong recommendations are what drive quality indicators that accountability reporting and payment programs might use. Conditional recommendations, we say the benefits could outweigh the risks, but there might be circumstances or patient values and preferences where a recommendation would apply versus would not apply. And these can be hotly debated in terms of whether or not they should be a part of accountability reporting and payment programs. So what things can increase your confidence in treatment effect estimate, or in what things can decrease the quality of evidence? So factors that increase the quality of evidence are usually a large magnitude of treatment effects, so a very large absolute risk reduction, very large relative risk reduction, a dose response gradient. So if a drug has a 50% beneficial effect at a dose of 5 milligrams, that increases to a 70% effect at 10 milligrams, that increases to a 90% effect at 15 milligrams. That again increases quality of evidence. Factors that decrease is if the study itself is not well done, if the results seem inconsistent, if there are imprecise estimates. And what that means is if we get a measure of treatment effect and we look at the confidence interval, and the confidence interval is really wide, that suggests that we are truly unsure where the true measure of treatment effect lies as compared to if the confidence interval is really narrow. And then publication bias becomes very important. It is no secret that, studies with positive findings are more likely to be published than studies of negative findings. And so if they do analyses while conducting a systematic review and find that there's significant publication bias, that can definitely rate down the quality of the evidence. So One question that comes up is, how can we know if a guideline is trustworthy or not? A lot of guidelines can be anywhere from 20 to 60 pages, multiple recommendations, multiple stakeholders involved. Like, how do we know that this guideline is something we should use? So I've listed here some questions that I think are important for us to think about. So one is the clinical questions the guideline attempts to answer clear and comprehensive. I always like to think about this as, if you look at the guideline recommendation and you think about the care of a patient that you've seen recently with that condition, could you see how this question relates to the patients you see? And if it doesn't relate at all, or it's not clear, that is a red flag. Is the recommendation based on current evidence? Of course, all guidelines should do a very rigorous search of the literature, and we should be using the best available data and evidence to make recommendations. But if it is unclear how they search the literature, and if it is unclear the manner in which they decided to include certain trials versus not, that would again decrease the trustworthiness of the guideline. Are values and preferences associated with the outcome specified? Again, going back to our discussion of the rules of EBM, we mentioned that evidence alone is not enough. So yes, it's great if something is a strong recommendation, but there should be some discussion of what patient values and preferences should be considered with the application of said guideline recommendation. All recommendations in a guideline should have a strength level associated with them. Again, usually strong, conditional, or weak. And you should be able to understand why the authors of the guideline assign that level of strength to the recommendation. And then, was the influence of conflicts of interest minimized? Certainly, for a lot of guideline committees, they have a pretty rigorous and robust process to deal with conflict of interest. In some guidelines, for example, if a person has a conflict of interest, they can participate in the discussion regarding the evidence of a guideline. But when the formal vote happens to say, should we say this is a strong recommendation, a conditional recommendation, a weak recommendation, they actually have to recuse themselves, or they might be recused by the committee. That is one example. Some guideline committees will not allow an author to come on if they have a significant conflict of interest. So guidelines will differ in the manner in which they address conflict of interest. The most important thing is that all due efforts are taken to make sure that those conflicts of interest are not significantly impacting, the recommendations that come from the Clinical Practice Guideline Committee. So I alluded to on the other side that these recommendations can be multiple pages. And for the practicing clinician like myself, who saw 19 patients on Monday, it is not feasible to be able to sit and read a 60-page guideline and try to make sure that I am seeing patients and taking care of other matters that might come up in clinical care. And for this reason, there's been a lot of interest really since the mid-2010 range to create what are called clinical guideline synopses. So what these are anywhere from 1 to 3 page evidence-based critiques of guidelines, highlighting what are the strongest recommendations usually from a guideline, what is the evidence base behind those recommendations, and offering, critiques of the guidelines as well as kind of areas for future study. Now, what makes clinical guideline synopses useful is that they kind of give you a clear scope of the problem identified, that there's an appraisal of the evidence behind the strongest recommendation in the clinical practice guideline upon which the clinical guideline synopsis is built. that there's a critique of the scope or development of the clinical practice guideline, and that they identify areas for future study. Now, thankfully, there are a lot of places that publish clinical guideline synopses. The Journal of the American Medical Association publishes them, so does the Journal of Hospital Medicine. And certainly want to shout out our own Southern Medical Journal for also publishing clinical guideline highlights as well. And then for those that still engage in Twitter, often there will be those on Twitter who will do an analysis of a guideline with kind of an attention to the things that I mentioned in the previous slide. So these are places where you can go to see kind of clinical practice or clinical guideline synopses of major clinical practice guidelines. All right, so with those things in mind, let's use some clinical guideline synopses for everyday things that come up in the care of patients. So I'll start with a case. You have a 37-year-old woman on long-standing oral contraceptive pills presenting with a one-day history of exertional chest pain and dyspnea. Past medical history includes allergic rhinitis with no prior venous thromboembolisms, miscarriages, or evidence of bleeding disorders. For her social and family history, she is a non-smoker, she does not use drugs, she has rare alcohol intake, she works in IT primarily from a desk at home, she has no family history of VTE, miscarriage, or bleeding disorders. On review of her medications, she uses a fluticasone nasal spray daily as needed, and of course her oral contraceptive pill. Her examination, blood pressure is 145/79, her heart rate is 100, respiratory rate 28, satting 100% on room air. She is tachycardic on exam, but comfortable, and her other exam feature is unremarkable. She gets a D-dimer, and it is over 50,000 with a slight elevation in her troponin levels. And her EKG shows the findings listed there. She gets a CT angiogram of her chest showing a near occlusive pulmonary embolism in the right main pulmonary artery, extending into the branch arteries, emboli in the left lower pulmonary artery, and some bowing of the interventricular septum. Echocardiogram confirms right ventricular cavity dilatation, focal base free wall hypokinesis with sparing of the apex, and a severely elevated pulmonary artery systolic pressure. So want to do a little bit of interactivity here. And so maybe in the chat, and if Jennifer or Rob can just let me know what people put, what should this patient receive for initial treatment of their VTE? You can just put A or B or C or D in the chat. And then again, Jennifer or Rob, if you all will let me know what people are saying. Great.
Not seeing any responses just yet.
Okay. Okay. I'll give just a few more seconds here, and totally okay if not able to do it, I understand, but want people to think about this question. And maybe as a second thought question here.
It looks like we have our chat featured as actually disabled. So we will work on that. If there are other questions, we will get that fixed so we can do that going forward. And we apologize for that.
No problem at all. Thank you for whoever put that in the Q&A. while they're working on that, would you recommend this patient receive extended VTE treatment? Just want you to think about that question. Um, and then I'm gonna hopefully resolve those two questions by the end of our time together today. So in late 2021, there came out the CHEST guideline for venous thromboembolic disease. This was an update from a previous guideline, I think back in 2012, kind of answering questions around how should antithrombotic therapy be approached in patients with VTE. When we think about the scope of this problem, VTE affects about 600,000 people in the US annually, with up to 100,000 people dying from it. And given its idiopathic nature, the diagnosis and management of it is not always straightforward. And for this reason, this is why there's been so much interest in having updated guidelines about how to both diagnose effectively and, maybe more importantly, how to manage patients with acute VTE. So let's talk about who made this guideline. They develop a multidisciplinary group of internists, pulmonologists, intensivists, surgeons, hematologists, medical librarian, methodologists. I will say that this is pretty typical, and this is a very good sign. So, if you think about patients that have venous thromboembolism, they've probably captured most of the people that would be involved in caring for them. Certainly internists are important. Certainly lung doctors are important. Certainly surgeons if they're going to need interventional treatment, hematologists if they need workup for kind of hypercoagulability or other reasons to have VTE. For those that had primary conflict of interest, they were excluded from voting on recommendations. So going back to my comment, did they try to minimize, the impact of conflict of interest? I think, they definitely spoke about this and had a very clear process. They generated 17 what are called PICO questions, which stands for patient, intervention, comparator, outcome. And from those 17 PICO questions, they gave 29 recommendations, 13 of which were strong recommendations. So for initial treatment of venous thromboembolism, they talk about, direct oral anticoagulants really being the standard. Now, I will say that they made a note that the evidence was only moderate certainty in non-cancer patients. And part of that is two things. One, the very wide confidence interval. So if you see here, relative risk of 0.51 for dabigatran, 0.91 for all 10A inhibitors. So your apixaban, rivaroxaban, edoxaban, et cetera. But also because these results weren't statistically significant either. So moderate certainty in non-cancer patients. Now, for sure in patients with cancer, strong evidence from trials of reduced VTE recurrence, so a 38% relative reduction in the development of VTE if you use 10A inhibitors in patients with cancer. And treatment, they say, should be done for at least 3 months. And this is pretty standard. Now, when thinking about extended treatment, the guidelines kind of talked about the fact that this is a more nuanced discussion. As we look across trials, the duration of extended treatment is not well standardized. Some trials considered extended treatment 2 years, some 4 years, some 3 years. Now, for patients that had no VTE risk factors, there did seem to be benefit in reducing the rate of recurrent VTE. However, I would argue most of this benefit was obviated by the increase in major bleeding. There was also a comment that the benefit also was likely if patients had cancer or antiphospholipid antibody syndrome for extended treatment. But for the vast majority of patients with major or minor transient risk factors, that extended treatment was probably not necessary. So to answer the question of what should this patient receive for initial treatment phase of VTE, you can make an argument that a direct oral anticoagulant from the guideline perspective is probably what is needed. I know that some would argue for the use of intravenous heparin given the elevated PASP, and I don't think necessarily that's a wrong choice. I think that's a discussion with the patient about, again, what evidence we have, what concerns we have, what's risk and benefit of doing this. Of course, the risk with direct oral anticoagulants is a concern for usually clinically relevant non-major bleeding more than major bleeding. And would you recommend this patient receive extended VTE treatment? I would argue no. This patient does have a pretty significant risk, does have a risk factor with OCP use. And given the OCP use, if that OCP was discontinued, changed to a non-estrogen containing OCP, it's possible that the patient would have reduced risk for VTE in the future. And so after 3 months, unless there was some other intervening condition or something, would probably argue that this patient would not need extended VTE treatment. All right, so let's walk through another case. We have a 39-year-old woman who's evaluated because of a 9-month history of cough occurring during the day, but especially at night. She has to clear her throat often. She has no postnasal drip, acid reflux symptoms, dyspnea, or wheezing. She has never smoked cigarettes and takes no medications. Physical exam shows cobblestoning of the posterior pharynx. Chest radiograph is formal. So, as this patient is being evaluated and worked up for a chronic cough, try again here in the chat. Thanks so much to Jennifer for fixing the chat for me. Should this patient receive an empiric PPI? Just treating possible GERD as a reason that she has chronic coughs. I'll give you a moment there to kind of vote and see what you think.
You let me know, Dr. Jackson, when you want to hear if anyone is responding. I see 1 or 2 coming in, so you just let us know.
Okay, I certainly will. Thanks so much, Jennifer. We'll give another couple of seconds. And again, just a safe environment here. Just want to see what you all think. All right, did we get any responses there in the chat?
We do. Would you like me to share that? We have the response of answer B.
Okay.
It's come through. I don't see any others yet, but that we have seen B.
All right.
And, someone has answered A as well. Okay,
excellent. And what other testing could this patient undergo for GERD evaluation if indicated? Feel free to share it in the chat or in the Q&A box. I'll give a few seconds here before we proceed. A few more seconds here. All right. Jennifer, what do we have now in the chat?
We have 2 answers. It looks like we have esophagram and we have, let's see, the pH metry. So we have those 2 answers for you.
Excellent. Thank you so much. So in 2022, the American College of Gastroenterology came out with guideline for the diagnosis and management of gastroesophageal reflux disease, led by Dr. Katz and colleagues. So let's talk about the scope of this problem. $9.3 billion in healthcare costs are attributable to GERD almost yearly. And for ambulatory, for those of us who do mostly ambulatory care, it accounts for 18% of the digestive diseases encountered in that setting. It's unclear exactly the prevalence. It's somewhere between 8 to 26% of those in North America have either been diagnosed with GERD or believe they have GERD. So who made this guideline? Panel mostly of gastroenterologists and hepatologists. And I would say one of the criticisms that we wrote about this guideline was that it kind of gives a myopic view, a little bit more from the perspective of GI and hepatologists, but certainly PCPs, patients, other things could maybe provide some alternative perspectives, particularly around other lifestyle modifications, other treatments that could be tried for GERD. So that is one criticism of the guideline here as compared to the VTE guideline, where there are so many different perspectives at the table. They use the grade framework that we talked about before to make recommendations. So they either say recommendations are strong, conditional, or weak, with anywhere from high to low certainty. So this patient, one of the concerns could be, whether or not they have extra-esophageal GERD, and we see this sometimes in patients with chronic cough, throat clearing, hoarseness, sort of a globus sensation or signs, symptoms of laryngitis. Problem with extra-esophageal GERD is the symptoms typically are nonspecific and overlap with other diseases. There was actually a strong recommendation in this guideline to not use empiric PPIs, often because patients didn't really notice any improvement in clinical outcomes with them. And it could delay getting other important testing to try to figure out what is the cause, in this case, of the chronic cough. So I put this framework here that they put in the guidelines, and I think it's very important, for those of us who see these patients, that if somebody has extra-esophageal GERD symptoms, you really want to do a detailed medical history to see if there are other causes. And you want to see with their extra-esophageal symptoms if there's typical GERD symptoms. So if this patient had acid reflux symptoms and this chronic cough, absolutely doing a PPI trial for up to 12 weeks would be reasonable. And then if their extra-esophageal symptoms improved, treat as GERD. If they did not improve, doing some sort of reflux monitoring would be indicated. If they just have extra-esophageal symptoms, as was the case with the patient that I presented, then it would probably be more ideal to try to do some sort of reflux monitoring to see if they truly have GERD, and if that reflux monitoring was abnormal, treat as GERD. If that was not, then you can do more advanced testing. I just wanted to show that this is some of the advanced testing that can be done. This is esophageal pH probe, where they have a probe that basically the path of the probe goes down to the esophagus near the GE junction, which would be right here, stomach's here, parietal cells here that make acid. And this probe is checking for acid coming into the esophagus and then to a reader that then, the gastroenterologist could take a look at. So I would say, given just the extra-esophageal symptoms that their patient's having with no typical GERD findings, that you wouldn't want to do an empiric PPI at this time. And you'd want to do some sort of reflux monitoring with possible pH testing to document that this patient truly has GERD. And then from there, treat as appropriate with, PPIs. All right. Coming to the home stretch a little bit here, and this will be our last guideline we talk about tonight. So the case here is a 61-year-old professor suddenly collapses while giving a lecture. His students call 911 and he arrives at the emergency room 20 minutes later. Medical record review reveals a history of hypertension and hyperlipidemia. His medications include aspirin, losartan, and atorvastatin. On admission to the ER, his blood pressure is 222/95, pulse is 65, respirations are 12, and temp is 99.2 degrees Fahrenheit. He opens his eyes and moans to verbal stimulation, but does not follow command. He withdraws his right arm and leg to pain, but there is no spontaneous movement on the left. A head CT shows a moderately sized hemorrhage in the right putamen with minimal midline shift. It has now been a little over 3 hours since he collapsed. So my last couple of questions for you is, what is the optimal blood pressure target for this patient? So take a moment and look at it. You can certainly put your thoughts there in the chat. Now just give a second here on this slide. All right, looks like we got some responses there in the chat.
We do. We have a couple of C responses, and we also have a response of 120.
Okay. And then my second question, excuse me, is, should this patient receive an anti-epileptic or an AED as part of management for this fairly large ICH? All right, looks like there are some responses there in the chat.
We do, and we have one in the Q&A as well. So people are responding.
Excellent, excellent. What are people saying?
People are saying answer B as well as answer C.
All right, excellent. So gives us some stuff to talk about. So some of the next slides I did borrow from some slides prepared by the American Heart Association that are for free use. And so just want to talk a little bit about intracerebral hemorrhage. So when we think of strokes, 85% of them are usually ischemic strokes, and then 15% of them are hemorrhagic strokes, with most hemorrhagic strokes being intracerebral hemorrhages and then a few being subarachnoid hemorrhages. So we care about intracerebral hemorrhage because, as compared to ischemic stroke, there is a high rate of early term mortality with them. 30 to 40% of patients can die within a year. In addition, there are certainly disparities in ICH incidents, by race and also by those of varying socioeconomic status. Now, when thinking about who made this guideline, a lot of participants. So stroke neurologists, neurosurgeons, neurocritical care specialists, patient representatives. I did find it curious in looking at this guideline that hospitalists and intensivists were not included, which is kind of curious. I still think overall they have a pretty broad range of people involved in this guideline, but that was something that was a little bit more interesting. It was commissioned by the American Heart Association, and they made 124 recommendations related to primary ICH, similar to other guidelines for conflict of interest. Those with known conflict of interest could not vote on strength of recommendations or certainty of evidence, but they could participate in the discussions regarding them. So, we've talked a lot about grade recommendations. The American Heart Association and others kind of use a little bit of a different rating system. And so in general, they will rate the strength of a recommendation as strong, moderate, weak, moderate, and strong. And that goes from like class 1, where benefit significantly outweighs risk, to class 3, where risk significantly outweighs benefit. Okay. So in general, you know, we of course want to prioritize those things that are class 1 strong indications, supported hopefully by high quality evidence from multiple RCTs or a meta-analysis of high quality RCTs. And probably, if possible, try to avoid things that are class 3 and supported by lower levels of evidence. So in general, with ICH, you can have primary ICH, secondary ICH. Primary ICH typically has 2 primary causes, hypertension and cerebral amyloid angiopathy. And these can be distinguished usually by hypertensive bleeds occurring in more kind of deep brain tissue areas, such as your basal ganglia, for example, as compared to cerebral amyloid angiopathy, can be kind of in a more lobar distribution. Secondary ICH, which was not covered as much in this guideline, are usually going to be from things like hemorrhagic tumors, AV malformations, maybe even infective endocarditis in some cases. And the issue with intracerebral hemorrhage, and why we care so much in this guideline, is that it can cause brain injury through multiple mechanisms. You can certainly have the expansion of the hematoma compressing on brain tissue, which raises ICP, which then decreases blood flow to the brain, causing brain deforming mitochondrial dysfunction, which leads to inflammation, edema, cell death, and if unchecked, can lead to herniation and death. But you can also get secondary brain injury from the inflammation breakdown of the blood-brain barrier. There are multiple risk factors for ICH. The biggest one is hypertension, usually seen about 75% of patients. And patients in the 6th, 7th decade of life are more likely to be affected. As kind of very common risk factors for this condition. So thinking about blood pressure, they actually talk about this a lot in the guidelines. So they say it's a 2A recommendation. So that's going to be something that has still benefit more than risk, but it's not strong enough to say that everybody should do it, but probably most patients should have this treatment. So there should be medication titration to make sure smooth and sustained control of blood pressure, and try to do that treatment within 2 hours of ICH onset to reduce the risk of hematoma expansion. And if they're coming in with mild to moderate severity ICH with a blood pressure goal of 150, a systolic blood pressure between 150 and 220, acute lowering of the SBT to a target of 140 with the goal of maintaining the range between 130 and 150 seems to be safe and reasonable. If there's large or severe ICH requiring surgical decompression, we truly don't know. If the ICH is mild to moderate and they're presenting with the SBP less than 150, they actually don't recommend lowering less than 130 as it could be potentially harmful. So there is some degree of blood pressure lowering that is necessary, but you can go too low in these cases. And the reason that actually comes up is because your blood pressure does need to be a little bit higher to maintain cerebral perfusion pressure. Now, the other thing that the guideline talks about here is seizures and anti-epileptic drugs. So in patients with a intracranial hemorrhage without suspicion of seizure or anything, is actually a class 3 harm, no benefit. You really should avoid anti-seizure drugs. There is a 2A recommendation that they have unexplained abnormal fluctuating mental status, suspicion of seizures, getting a continuous EEG is reasonable, and if you confirm a clinical or electrographic seizure, administering an anti-seizure drug in those cases would be helpful. I do apologize. This is an error here. It should be, systolic blood pressure target of 140 is fine as long as it's not going less than 130. So apologize for the mistake there on the slide. And I would argue with with this patient that you don't have any clinical evidence yet that they have had a seizure. So I would say no in terms of giving anti-epileptics for this particular patient. The patient might benefit from getting continuous EEG based off of the case presented. So to conclude, guidelines give us a roadmap to consider diagnostic and therapeutic decisions for patients, but they are guidelines. We still have to consider our clinical experience, our patients' values and preferences in applying the guidelines. Strength and certainty of guidelines are determined by a review of the available evidence and our understanding or knowledge of the estimate of treatment effect. DOACs have become and remain the standard of care for initial treatment of VTE, with the strongest evidence being in those that have underlying cancer. For patients that have extra-esophageal GERD, there is more benefit in testing as compared to empirically treating with PPIs. And I would argue less is more with antihypertensive and AED use in patients with primary spontaneous intracerebral hemorrhage. And with that, I thank you for your time, and that is my email.